This video will discuss acute tubular necrosis. So what is acute tubular necrosis? So acute tubular necrosis is characterized by acute decline of the renal function and tubular injury. So actually in acute tubular necrosis, you can see this word last is necrosis. Now this necrosis, not all cases show necrosis. So therefore the term nowadays which is preferred is acute tubular injury or acute kidney injury, because necrosis is not seen in each and every case, and it is the most common cause of acute renal failure. Now in this video we will discuss about the causes, we will discuss about the pathogenesis. So causes, mainly there are two main causes. One is the ischemia and second is the toxins. Okay, so these are the two main causes. Ischemia, that means there is decreased or interrupted blood flow to the kidney. This can be due to, as the patient is in hypovolemic shock, or there is any problem in the intrarenal blood vessels such as in HUS, okay, in DIC, in TTP. So these lead to any problem in the intrarenal blood vessel, which will lead to decreased blood flow to the kidney. Then there are toxins. Now direct toxic injury because of any endogenous or exogenous injury can agents can cause injury to the tubules. So endogenous agents such as myoglobin. So if the patient is in rhabdomyolysis, then hemoglobin, bile, so these can also cause injury to the tubules. Then exogenous agent, that means the things we are taking from outside such as gentamicin, radiographic contrast agents, mercury, carbon tetrachloride, these are known to cause toxic injury to the tubules. Then any hypersensitivity reaction to the kidney can also lead to acute tubulointerstitial nephritis. And lastly, any post-renal cause such as obstruction, okay, after the in the ureter, after the ureter, so there is obstruction by the tumor, prostatic hypertrophy, or any blood clot. So these can also cause, but the main two causes which you should remember are the ischemia and the toxins. Okay, these are the main important two causes of the in the ATN. Now pathogenesis. So pathogenesis, if you see, there are two main things which are happening. One is the tubular injury. What do you mean by tubular injury? So there are tubules. Okay, first there is glomerulus, then you have your proximal convoluted tubule, okay, then distal convoluted tubule and all that. Okay, so these tubules are lined by tubuloepithelial cells. So there is injury to these epithelial cells. These epithelial cells which are injured, they can slough off, okay, they will die, they will slough off from here. Okay, so tubular injury will take place. Second is any problem in the blood flow. So going to firstly the tubule cell injury. So now why the tubular epithelial cells are so sensitive to ischemia or toxins? Why they are not resistant to it? Because firstly tubules are meant to reabsorb things. Okay, so there is increased surface area for tubular reabsorption. Now what will happen if there is any toxin? The tubules will reabsorb it because they have very high surface area, and this will lead to tubule cell injury. Also there is active transport system for ions or organic acids. So these all because the kidney, the tubules have to work so much, they have a very high oxygen consumption. So if there is ischemia, so they are very sensitive to it. So if there is ischemia, there will be decreased oxygen there, and it will lead to tubule cell injury. Secondly, there is disturbance of the blood flow. So disturbance of the blood flow, if there is ischemia to the kidney, it will lead to vasoconstriction in the renal. Okay, so before we are discussing the pathogenesis in detail, you should know about what is tubuloglomerular feedback mechanism. So if due to any reason there is decreased glomerular hydrostatic pressure, that means if there is hypovolemia in the person, okay, so there will be decreased arterial pressure, there will be decreased hydrostatic pressure, it will lead to decrease in the GFR. So decrease in the GFR automatically activates your RAS system. So when the RAS system is activated, there is increased efferent arterial resistance, which will give a negative feedback and will try to compensate. Okay, so this is the normal physiology. But what happens in case of ATN? Okay, in ATN what happens is, if we are talking about ischemia, Okay, so what will happen, ischemia will act over here, okay, and toxins will directly act over here. So ischemia will lead to vasoconstriction in the kidney. Vasoconstriction will lead to increase in the RAS system. Okay, and it will lead to reduced GFR and oliguria in the person. Okay, then if there is tubule cell injury, now tubule cell injury can be irreversible or reversible. So if it is irreversible, that means because of necrosis and apoptosis there is a there is direct injury to the kidney, direct injury to the tubules. But also when there is reversible injury also, there is loss of polarity. This loss of polarity will cause increased sodium delivery and will increase the tubuloglomerular feedback. Whenever this will happen, there will be reduced, this will lead to reduced GFR, and this will lead to reduced GFR and oliguria. Now going to the morphology, the ATI is characterized by focal tubular epithelial necrosis. So what happens here, you can see in this diagram, we can see there are two types. There is ischemic type and then there is toxic type. So what is the difference between morphology? If you see the tubules, so in ischemic part, the red part, this denotes the necrosis, and the blue part denotes the, this part denotes the casts. So two things are there. First is the necrosis. Necrosis means death of the tubular epithelial cells. So here in the ischemic type, this is patchy. Okay, so you can see in between areas are normal, however it is certain parts are involved. In case of toxic type, this is fully involved. Okay, this is diffusely involved. So this is the toxic type, and the casts are formed. Okay, there are two things, there is necrosis and casts. So uh, if you see the casts now, first is the necrosis, which I have told you is patchy, and here it is diffuse. Casts are what? Casts are formed due to any tubular injury. Okay, because of this, the casts are formed from TAM protein. So TAM protein, which is normally present along with the tubular epithelial cells, they will form casts. So these are the two things which are seen morphologically over here. So now we are seeing that some part of the kidney is involved, tubule. This is necrosis, but this part is normal. So this normal part, what will happen is, this is the normal part. What will happen is, whenever the ischemia goes away, whenever the toxin will go away, okay, whenever the patient will improve, this part will lead to reepithelialization, and this will cause the recovery in the person. So ATN is reversible process. Okay, now morphology also depends, there are certain particular things about any toxins. So whenever you are seeing if you are talking about mercury chloride, if the mercury chloride is causing ATI, the patient, the cells, okay, the tubular epithelial cells, they will have large acidophilic inclusion. These are certain things which are particular to that poisoning. Similarly, if you have carbon tetrachloride poisoning, they, in the injured cell, firstly what will be there, there will be lipids which will be present, then some fatty change is happening, and fatty change will be followed by necrosis. Now this is also again particular to carbon tetrachloride, these are not particular to ATN. And in ethylene glycol poisoning, what will be there? There will be ballooning and hydropic degeneration of the tubular epithelial cells. And also, very importantly, calcium oxalate crystals are found in the ethylene glycol poisoning. There are certain pointers, there are certain, you can say, one liners. Okay, so what you see in ethylene glycol poisoning, you will see ballooning of the tubular epithelial cells, and calcium oxalate crystals will be seen. So going to the clinical course. Okay, now clinical course is, the patient presents in 3 phases. Okay, so the first phase is the initiation phase. So when the person is abruptly, because of say any obstetric cause, okay, patient because they have lost lot of blood, so this is due to any cause. Firstly, the patient will present with decrease in the urine output with slight raised in the bun. This is the first phase. Then second phase is the maintenance phase. In this phase, the person will go into oliguria. Okay, there will be decrease in the oliguria, and there will be increased bun. Okay, there will be hyperkalemia which will be happening. Okay, because the urine is not there is decrease in the urine output. So this is the maintenance phase. Now last is if the patient goes into recovery phase because there is toxin levels are low, or the patient has recovered from the ischemic attack. So recovery phase, so in recovery phase what will happen is there will be again very increase in the urine volume. Okay, there will be very high urine volume which will be happening. There will be around 3 liters per day can also go. So but what will happen is the tubules are damaged, so large amount of the things which were going to be reabsorbed by the normal body will be now excreted in the urine. So here the problem comes is hypokalemia. So if your patient is presenting in the maintenance phase, then the problem is hyperkalemia. But if the patient is presenting in the recovery phase, hypokalemia is a very important clinical problem which is encountered, and also infection can also take place. So this is the recovery phase. The two problems which a clinician faces: hypokalemia and infection, which can occur in the recovery phase. So this is all about the acute tubular necrosis. If you have any queries, do ask in the comment box. Like, share and subscribe to this channel if you like these type of videos. Thank you.